Today, we're going to talk about some gaps between our training and when boots hit the ground. Find out more next. Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia care. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for conversations aiming to bridge the gap in dysphagia education and practice. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. Through critical reasoning and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. So glad you joined us. Today, I have Dr. Jordan Hazelwood. She is an associate professor and the Communication Sciences and Disorders undergraduate program director coming up here in January, which could be the present time, depending on when you're listening to this, in the Department of Rehabilitation Sciences at Appalachian State University in Boone, North Carolina. She is passionate about training and education of clinicians and students in dysphagia management while considering the impact of standardized procedures, physiological dysfunction, and quality of life health outcomes. A lot of things I also like too, which is probably one reason why Jordan is here with me today. I want to talk a little bit about competency-based education in dysphagia. But if you're not in education, please don't run away. This affects you. This impacts you. I promise you. I mean, think about... Yeah, students, think about how you felt when you were thrown out there with a lower level of competency, not because you're not smart, but because of how our education is set up right now. So very pertinent to us. With that, I'm going to turn it back over to Jordan. Say, is there anything else you want to tell us about yourself? Or let's get this conversation started. I'm excited.
Well, I'm just really glad to be here. So thanks for inviting me, Tim. I know we've been trying to connect for a while. I recently have really been having a growing interest in competency over the past couple of years. And now that ASHA is moving towards competency-based standards, we definitely know that this is going to be a hot topic in the upcoming years. And as an educator and a clinician and a researcher, this is something that really interests me because it's a great intersection of all the different areas within our field. I definitely feel like dysphagia management isn't just another area of practice. It's really one where competency can actually literally make the difference between safety and harm, and is often what is most intimidating for students as they're learning about dysphagia, or also for clinicians who are wanting to transfer their skills back into the medical field. And many of us remember that our first dysphagia rotation was very tricky and intimidating. We felt very uncertain about the decisions and wondering if we were actually really ready. So I'd really like to just discuss with you today about how we define competency, how we can assess it, and possibly build true dysphagia competencies so that clinicians can feel confident and patients can get the safest care that they can possibly get.
That sounds wonderful. This is literally the major premise of this podcast is to get there. And so I know you're doing a lot of work in this area. You did a talk at ASHA recently in November of 2025. It was one of the few ones that I saw there. And I just know you're very invested in this. I would love to see how you think we're going to get there.
Well, I'd like to start by talking about there's a real critical education to practice gap. And the first thing is that we have a challenge that is quite big that's in front of us. As we know from some of my work and others, many graduate students report feeling insufficiently prepared and their confidence is low when carrying out dysphagia assessment and treatment independently. And even though they meet specific certification or coursework requirements, novice clinicians frequently lack adequate exposure to different types of cases and real-time clinical decision-making examples. So I really want to talk about how we can integrate simulation-based dysphagia training because it shows promise for improving students' confidence. It also can help us highlight the gaps that students feel in traditional training environments. And we also want to think about the difference between classroom preparation and readiness for autonomous practice. Oftentimes, employers are expecting students to be autonomous and independent upon their first hiring or for employment. And we know as clinicians that that's just not the case. And so how can we bridge that gap between when we're graduating students and when we're hiring them? That mismatch is the real big problem, is that employers do expect that immediate independence despite the fact that graduates are actually just starting to build their confidence. And we know that clinical settings often assume that independence from day one, even when transitioning from, a graduate program into a clinical fellowship or out of a clinical fellowship into their fully fledged licensed seed position. We also have to manage productivity pressures. There's limited onboarding structures for new clinicians. Oftentimes we have clinicians that are traveling or practicing in independent rural areas, and there is no good supervision or mentorship available for them. Health systems often emphasize rapid integration into interprofessional practice. While that's really great, oftentimes SLPs don't get a lot of good training about what the other fields do. And so they don't necessarily represent our field in the best way possible because they don't understand how we relate to the other fields and how we can work together as a team. And given the fact that there are different standards and regulatory bodies that outline competencies, but they don't always align with real world demands, that really places a high level of a lot of load really on new and novice clinicians that are out in the world. So the reality is that there's actually a really steep jump from classroom theory to real world clinical complexity. We know that real world dysphagia cases involve comorbidities. These patients aren't walking around with just dysphagia. They have fluctuating status. The context in which those challenges can really exceed what we can teach for students that are enrolled in the classroom. So dysphagia intervention requires integrating motor learning principles, instrumentation, preparation, evidence-based behavioral strategies. And those skills can really only be developed through extensive clinical repetition. So doing it one time, do one, see one, teach one, is not necessarily a method that works super well for us in the idea that our patients look different every single time. And when we have students that are starting to report the difficulty in navigating that shift from guided practice to autonomous clinical problem solving, it really becomes an issue for the patients downstream. So I want to really advocate for frameworks like that are standardized in assessment and treatment and practice, because it really helps us understand the knowledge and skills that are required and hopefully will help exceed what some training programs actually deliver. Ultimately, there's a huge impact in this. There's this persistent system-wide strain that's combined with that variability in patient care. Because patients see such variability in direct thoughts, clinical decisions can be difficult for clinicians to understand for direct patient outcomes. Health systems and workflows can be inefficient as well, especially when new clinicians require time to reach competence. And we also have curricular inconsistencies between programs and within programs from undergraduate to graduate curriculum, and thinking about how those can flow in the classroom, as well as coordinate with clinical education and classroom education. All of those things can help provide adequate training. However, we have to understand that variability across programs and even management skills can be difficult.
This is it's a mammoth of an undertaking to try to make this work as things are. I mean, just the variability that you mentioned in almost 300 programs, putting students out. Like I can think in one program, and everybody think back to when you were in graduate school, you had a coursework and then you had stuff in the clinic. The integration between those two things, like how well they were aligned, is a challenge, even in places where they're really trying hard to make it work. It is a challenge. And so, you can imagine for programs that don't prioritize that as much, that it's even more of an issue. But the cognitive implications of this on the individual, the speech pathologist, to me are remarkable. There are a few, I don't know whether to call them biases or a few type of learning curves to look at. I mentioned the Dunning-Kruger curve a lot. But you think of when you learn a little bit, you overestimate your capabilities. And then as you learn more, you're like, wow, this is more complicated than I thought it was. And then your confidence kind of crashes. And then you get to a point where you keep learning and you calibrate your confidence with your competence more. They become more proportional. Yes. And I'm hoping, that's where I am right now. It's a continual process. Sometimes you're like, oh, I really got this, and other times you're like, I don't know anything. So it's not quite so clear cut. But with me, the reason why I mention that is because you take students who new clinicians who graduate after one course with dysphagia and maybe some work in their graduate program or clinical rotation, and they have this mammoth of an undertaking to understand how swallowing impacts nutrition, hydration, quality of life, pneumonia, risk of asphyxiation, the knowledge of swallowing physiology with, 25 plus muscles and muscle pairs, several cranial nerves, a central pattern generator that causes this hybrid voluntary involuntary process to happen in under 2 seconds. And then the respiratory swallow coordination, like all these different things. And that's in a perfect, you're not even taking into consider patient variability, right? If you get
Right.
an 80-year-old lady who is ill and has diminished functional reserves, like swallowing is typically a sub-maximal task, but you get someone like that with a UTI, then she could be acutely ill and have transient dysphagia related to that. I'm not saying things right now because I want everyone to walk away knowing these. I'm just trying to exemplify the undertaking this is to be able to work with patients with dysphagia. It is huge. And so when you put people out with and give them, a bow and arrow, a slingshot to try to fight this monster that they have to overcome, it does something to you inside. Like we've been told, you fake it till you make it, which is horrible advice. But how do you get through that? Do you just go out and you're like, I don't know anything? Like, I think it puts us in a place where we're really inclined to have to try to fake it. And that just creates all sorts of different problems. I could talk about this for a long time. Sorry, Jordan, I don't mean to hijack this. It's just, it hits home so hard.
Well, there's ethical implications too, right? We put the onus on the clinician to go out and say, I don't have the skills, I don't have the knowledge, so I need to find someone to help me. And that's assuming that person actually takes the initiative to, one, recognize the fact that they don't know what they're supposed to know, or recognize that they don't know how to manage a case. And then the next step
That
is
assumes
assuming,
self-reflection, self-awareness. And so
right,
that's the best case scenario. Best
right.
case.
So assuming that actually happens, now we have to think about, are they pairing themselves with a mentor, and are they critically, picking that mentor or vetting that mentor? How do they know that person is actually credible as an expert and doing the same thing? So yes, it's difficult. The other thing too, and you mentioned the Dunning-Kruger effect, yes, that confidence tanks. And so what can we do in students to let them know that it's okay to not feel like you're
Mhm.
right all the time? It's okay to feel like, you will be learning. And we say that all the time. It's okay, you're learning, but they don't want to fail because they know that there's so much pressure to do things right because dysphagia is such a big deal. So when we're talking with students about going out into the field, trying to decide, do I know this? Do I need to get more training? We're always also trying to train them in critical appraisal and critical thinking. Some of the things that I like to integrate into my assignments are, what would be your next step? And since you don't know what the next step is because you're a student, what are the resources that you would be using? And then
Sure.
let's talk about what those resources look like and what those biases are that pop up in those resources, that we can help them start to think through the process. And a lot of what I'm teaching is dysphagia based. I mean, specific skills and understanding of what it is that you're supposed to know about anatomy and physiology, those things that you mentioned, but also just the process of becoming a clinical thinker. We talk a lot about critical thinking, but there is a clinical process that a lot of times clinicians who've been practicing a lot for a long time, they have this in their head. And that's often I would say, the invisible puzzle piece that students are always trying to get to. They say, well, I don't know how my clinical supervisor came up with this answer. How did they go from A to G? I'm still over here trying to get from A to B. And those in between steps are those sometimes what we consider to be the hand holding, but that's what the students need to see, that invisible labor or that thought process that we go through for that clinical process, so they can see what that roadmap looks like. And then when they're working through their critical thinking along that roadmap, that's when we can just say, okay, in this case is different because, we're going to turn left instead of turning right if we're using this map analogy, continuing right. And the reason we're turning left instead of right is because she is 80 years old, or because she has a prior stroke, or because she has XYZ, whatever those patient factors are. And that's where that flexibility of thinking comes in and the independence of becoming an independent clinician. But it's tricky because there's not enough time in the day for the clinical training, but also for clinical education for students to see every single type of patient that there possibly could be. So the process that they actually need to learn is not all the different examples. It's trying to decide how to apply the knowledge and pivot that knowledge to what the examples might be and based on certain factors. So that's the critical decision making part that's needs to be happening in the training process. You're muted.
Well, you look probably better off that way. But this makes me think of when I took my dysphagia course. It was the reason why I went into speech pathology. I thought dysphagia was fascinating. And I memorized the stuff in the course, and I had this theoretical framework, but it didn't make sense in terms of like translating it to clinical work. And I didn't get that until I went to the VA and did a traineeship there, and I was seeing patients. I'm like, oh yeah, this makes a lot of sense now. So I think sometimes in just your dysphagia coursework, you miss the big picture, like you have some knowledge and skills, but what you said is you don't understand how that plugs in to a clinical picture.
Right.
Right.
And I think that's where clinical exposure becomes such key, right? So when I have my students in my dysphagia class, some of them have already been in a medical setting. They've been doing their medical practicum. Some of them have not. And so the ones that have, they bring some good knowledge into their peers and they can talk about what it's like. But I also can't assume that their experience in a skilled nursing facility is going to mirror their experience that they would have in acute care. So the other thing we have to think about is the variety of settings that we work in. But there are some underlying common denominators that students need to have when they go out into the field. They have to understand all those basic things like vitals and trying to understand the positioning and even just how to find the patient's room and charting in the EMR. All of those things are learned skills, but they're not skills that need to be taught explicitly. Oftentimes those are the on-the-job training skills, but that right there is one of the, going back to that cognitive load that you were talking about, the on-the-job training skills are oftentimes where students get bogged down. They get scared and intimidated because they can't find the nourishment room. They don't know where central supply is. They can't remember which elevator they're going up and down. And so their brain is too busy trying to figure out where they are in their space. And then by the time they arrive at their patient's room, they're already tired. And so thinking through that clinical decision making, that's difficult, right? Adding all that stuff in. So the other thing to think about when we start to talk about integrating simulated learning, if a student has been exposed to some of those things like how to introduce yourself to a patient, how to take vitals, how to move the bed around, how to manage and manipulate the bedside table, how to get the passing mirror valve out of the little container. All of those things are things that they can do through simulated learning, hands-on training before they even get to a clinical setting. And that allows them to feel more comfortable with doing actual patient care. And they can move outside of their own, proximity of self and move more distally out toward the patient and focus on patient care.
So Jordan, I'm thinking of this in terms of cognitive resources. All right. If you're trying to drive down the road, you don't know where something is and someone gave you directions, you really got to focus.
And you turn down the radio.
You turn on the radio and but if kids are in the backseat, like mom, dad, this and that, and like I don't know, there's noise outside, there are distractions. You don't have the same sort of cognitive resources to focus on finding where you're going because you're using your selective attention. And so this is like, a scaffold of sorts. You're supporting them in different areas so that they can really focus on the critical thinking. Let me really fast give an example. Just people probably understand it already, but this last weekend I taught an in-person fees course. And one of the things that we did is we would have students do passes But then we would have them go through like an entire protocol. Like they would
Yes.
come up with this protocol and I would give them an example and I would say, this is my rationale for going this way. But they would have to come up with a protocol and give a rationale for why they're going from here to there, et cetera. But the scaffold that was provided is they would pass the scope, but then me or another instructor would take over with the scope so they could focus solely on their protocol and just learning one thing, at a time. So they're not having to think of like the mechanical skills of how do I turn the scope to get a good view and this and that. Like we'll get to that. But like we're showing the view so they can go through their protocol and really focus on that. Like even having like if you're trying to focus in a meeting, having your cell phone in front of you, you're actively inhibiting the impulse to pick up your phone. There have been studies on this, I think the University of Texas in test taking. Like it's a freaking big deal. And so
I agree
anyway.
totally. And I think the point that you're trying to make too is passing the scope is the easy part. And that's the part everybody thinks is the hardest, right? Like, oh,
Mhm.
I'm nervous. What if I hurt my patient? I'm like, you'll get that. The interpretation is the tricky part. And then what do we do from there? And then how do we manage to see if there's any improvements? How are we managing that care plan or the discharge plan? So yeah, I love that you're taking away that mechanical side. Like eventually you'll get the hands-on part, but what does it mean when you see certain things? Same thing for video fluoroscopy. And this is, oftentimes that same conversation. Well, my supervisor is recommending this, and I just don't know why or how they got to
Mhm.
that decision based on what we're seeing. And I can see, yes, there's aspiration. No, there's not aspiration, or, you know, obviously some other physiologic issues that are coming up. But what are the other factors, the patient factors, the family support factors, the scheduling factors, the logistic factors, the financial factors? What are those factors that the patient has that's unique to them that the supervisor is also integrating into their decision? And the student will say, oh, if I had known that, then yes, that does change my decision. So, and we try to target this in the classroom using case studies. And one of the things, since we're talking about scaffolding, one of the things that we've been trying to integrate into our program is scaffolded case studies so that we can use the same case study across multiple classes. So we're talking about the same patient and students become familiar with this patient, and we're not tailoring it to a dysphagia specific case study. We're saying, okay, you have this patient. What is their risk or what is the potential for having dysphagia or dysarthria or a stroke or all the other things that we might think about from speech pathology standpoint? Because when my students come in, they have their dysphagia hat on. And if they're only thinking swallowing, they're going to be missing other things too, right? So we really want to make sure that they're an SLP first and they're thinking about the patient altogether. And even the opposite, when you have an eval that's for dysphagia and you walk in and you're thinking about dysphagia and the patient doesn't even have dysphagia, what do you do, right? Or how are you making that decision? But there's other things, cognition or other types of referrals that need to be happening to OT or PT or psych or something else. So when we start to think about how we're managing case studies in the classroom, I really want to emphasize the use of real world case studies and not any contrived case study where we're just throwing in low SCS and, uncooperative family and, oh, now she has dementia and like all these things that we're trying to incorporate into a case study so that we can check a box and say, we managed these types of things on our guidelines, but instead using a general case so that we can have students thinking about it from that 30,000 foot view and not just at the level of dysphagia.
Well, I think in translating this to the SLPs who are listening, who have students at their externship sites or who have clinical fellows and whatnot, to me, it's very important to have time to talk about the cases, of course, but practice thinking aloud your thought process, your
Yes.
critical thinking. Like I'm identifying these variables as being integral to my decision making. And this is how I'm critically thinking through it. I think that sort of thing is modeling the method and the critical reasoning, the clinical problem solving. And if you model that method, then the students are more likely to catch on. And especially with these cases, like there's so many different variables involved and it can be overwhelming. But when you're talking through it or talking about it aloud, it helps students to bridge, or students, interns, externs, CFYs, to bridge things and see relevance in a way that they wouldn't see in a classroom, just learning like, definitions and that type of thing. So I'm just trying to think of things that would really translate to the listeners, and then regardless of whatever setting. Actually, so one more thing with that, think about like all of the things, like we neglect all of the little pieces that allow us to be a successful clinician. So Jordan, you mentioned adjusting the bed. You mentioned vital signs. Like all of those things are things we learn over time, and we forget how much time it took to do that. And so we get students, or we get more novice clinicians, and we're just like, why don't they understand this? And we forget all those little pieces that led to it. And so I think it tells us we need to be, of course, more humble in looking at that. But also, I mean, that's a major part of what it is, being more humble, because I think if we don't break down some of these case processes of like, this is an important variable, Y is an important variable, Z is an important variable, and that's how I came to my decision, that others who are learning from us can make mental shortcuts that ultimately can lead them to erroneous conclusions in other settings. So in sum, I think really focusing on verbalizing the critical thinking piece, critical reasoning through this, help students and more novice clinicians to learn the method of how you get to decisions versus just saying, oh, this patient needs to do a chin tuck or whatever, and force those who are watching to potentially make mental shortcuts or be subject to their own biases when trying to understand this process. It needs more discussion.
Oh, so I completely understand. And I want to go back to this idea because you're talking about processes, which really are what we're trying to measure with competency, right? So there's competencies, which are the things that you can do, the check boxes, but competency is being able to apply those check boxes to various areas, contexts, and concerns and things of that nature. When we are transparent with the processes, then that's when we can actually say, okay, you can do the skill, I can check it off, but can you apply that skill in a knowledgeable, applicable way? That's when you actually start to achieve competency, right? And that critical thinking is a huge part of that, because if you can have the skill, you can do putting on your gloves correctly, and you can do a clinical swallow exam, but you don't do it in an appropriate manner for the appropriate patient. You're not skipping the steps you're supposed to skip, or getting more information about the things you're supposed to do, or modulating it the way you need to fit the patient's needs. Then that competency of being able to do a clinical swallow evaluation is not achieved.
Yeah, so you've got to be adaptable to different contexts, different settings, different patients.
Yes. But also, I mean, if we think about cultural competency, right, their literature says that that's never achieved. You never achieve clinical competency or cultural competency. And I would argue the same thing for clinical competency. We never achieve the full competency because we're learning how to apply the competencies in various areas or situations or contexts. But doing those skills, like you talked about, bed positioning, we can check off a competency, right? But having competence and being able to apply those in the appropriate way, that also is what makes us better clinicians. And it makes us better clinicians, not because we can do the thing, but because we're treating the human behind it, right? If I know, oh, you look really uncomfortable and I need to get you situated and upright before we go in and start putting a scope in your nose, then that's going to help your patient respond to you better, and you're going to get a better outcome of your exam regardless. So yeah.
Yeah, a lot of different things. I tend to be an individual who is very overly optimistic about like the things that I can get done. I'm like, oh, that won't be too bad. This won't be too bad. And I think that mindset is also applicable to working with patients who have dysphagia too, right? You don't realize the level of detail and the level of different factors depending on, is someone in a SNF? Are they in acute care? Are they in inpatient rehab? Are they in outpatient rehab? I mean, knowing the differences between insurance, knowing how much time you can justify spending with your patient, positioning requirements, their access to their medications, their access to supervision with meals or whatever that they need. There are just so many different variables that unless we're immersed into it or immersed into case studies, at least as a roadmap before we get into this clinical immersion, it's not something that can be understood apart from experience. I think. I don't know that there is any way to teach this apart from experience. So I would just say to those listening who don't have a student, consider taking one, especially if you're
Please.
passionate about it. Like, please consider taking one. Not only I think will it add such a rewarding dynamic to your life and your clinical practice, but if you're someone who is concerned about making this field better, like you're going to pass along that ability and you're going to pass along that passion. So that's one thing. If you don't have a student, consider taking one. But two, if you do have a student, like you've got the power to make a tremendous difference, such a big difference, so much more. And I mean, I don't mean to disparage those who are teaching in the classroom. That is incredibly important. I do it myself quite a bit. But I would argue that you potentially have more influence where you are. So, I mean, it's a big responsibility. Of course, take it seriously, but this isn't to imply that you wouldn't take it seriously. Just if you're passionate about this field and where we're going, realize the power that you have within that and make something of it. Talk about your cases with students, try to advocate for more time to be able to do that, because I know productivity constraints are there and make it very difficult, but just do what you can to make a difference. That's cliche, but that's maybe all I should say right now.
Well, I like to tell my students, go change the world one swallow at a time, right? But I think too, we use this word supervisor, and I've used it already talking with you, supervisors, but they're not just there to supervise. They're actually clinical educators, right? So their job, their voluntary job from the bottom of the goodness of their heart and trying to take a student to supervise them is to train them in the clinical practice within that specific context. And a couple of things that could make that easier for people that are in that role is to make sure that they're using standardized assessment tools, templating things that are helpful. There's the dysphagia competency verification tool, which can be found on the ASHA practice portal. That was designed to specifically help clinicians understand what areas of dysphagia management they could use some improvement or some mentorship in. And we just really want to make sure that we're using practice patterns that are consistent so that we can move the field forward, that are rooted and grounded in evidence, but also that are not restrictive. We want to be able to have some ability to individualize patient care. And when we think about new graduates, we think about the educators, both the clinical and the classroom educators, the programs and employers. There's a lot of demand for having good, skilled, and competent clinicians. And while there is no universal definition of what that looks like, we definitely think that we can have some interaction between those stakeholders, right? So clinical education, clinical expertise, professional growth, and on the onus of the individual, and supervisor mentorship, all of those things can play a role together so that the field, anybody who's coming into the field as a student, who has been in the field and is continuing to learn, or is changing scope of practice, maybe from a education-based, school-based SLP position into the medical hospital-based situation. Just because you haven't been doing something doesn't mean you don't know how to be an SLP, right? We're thinking about those processes or those underlying factors and how they can apply specifically to patients that have dysphagia. And then that's when specific skills come into play. So when I'm talking with people and I think about this idea of moving from novice to expert, the expert always becomes the novice again, because there's always something new and different to learn about, and it becomes spiral in nature, right? And again, going back to that Dunning-Kruger effect, the more you learn, the more you realize you don't know. And so then you have to become a novice again to figure out some of the things that you need to learn about. And it's on the onus of the clinician to do that. But I also want to really emphasize and encourage that bridging the gap between the university and the clinical sites. That became kind of a big issue during COVID because a lot of clinical sites weren't available to students. And we want to make sure that we are having collaborative training models, that we're sharing competency expectations, and that there's bi-directional communication between the university and the clinical site. And that being said, I'm doing a lot of research in my lab, and I would encourage anybody who's interested in helping us kind of shape what we're discovering next. We are currently analyzing a nationwide graduate level dysphagia course syllabi study. So if you teach a dysphagia course at the graduate level, please send me your syllabus and you can be included in our study so we can get a good picture of what people are teaching and how they're teaching it to our students. We're also working on developing a student version of the dysphagia competency verification tool, because the one that has been developed for clinicians is too high of a level. It's too structured for students. They haven't gotten there yet. And we also want to start to think about guiding dysphagia curriculum creation. So things that can happen in the classroom and help support those instructors who are clinicians that don't necessarily have formal pedagogical or teaching backgrounds or history or knowledge about how to actually put together a syllabus or design a class, how we can help them go in and feel more confident in teaching newer clinicians who are going to be doing dysphagia management. So those are some of the projects and things that I'm working on to help further this idea of the need for dysphagia competency, the need for critical thinking, because our training really impacts the end user, which is the patient. And we need to be able to prevent poor SLPing, if we will, down the line. We want to be the best clinicians that we can, and we can only do that if we have really good training from the beginning.
Absolutely. Yeah, so much to it, Jordan. I really appreciate your perspective, and I appreciate all the work that you're putting into this. If anyone's interested in connecting with Jordan, her email address is hazelwoodrj, that's HAZELWOODRJ @appstate, that's 2P, so appstate.edu, or check her out on Instagram. She is at Dr. Hazelwood SLP. Seems very, very interested in talking about this. I didn't even have to ask her for her email address and Instagram. She volunteered it. Sometimes I'm like, do you want me to put that out there? Very willing. So I would encourage you to reach out if these things interest you.
Happy to help.
And thanks again for your time. Looking forward to seeing the difference that you make in the future.
Well, thanks for including me, and I look forward to all the people that are going to be joining us in the field and all the great work that we're going to do for our future patients.
Yeah, it's getting better. I think it is. Thanks for tuning in to another episode. It's been a while, so we are particularly glad to have you with us today. A heads up on a webinar that's happening on May 23rd. It's looking at neurological disorders and the speech-language pathologist. Specifically, it'll look into ALS, Parkinson's disease, stroke, progressive supranuclear palsy, and myasthenia gravis, in addition to some neurological underpinnings of speech and swallowing. Check it out under courses at swallowthegap.com. Thank you so much for listening. Your support is tremendous, and we appreciate it. Thank you. Please don't hesitate to reach out, and we'll see you next time.